Welcome to The Explainer. Have you ever wondered what really happens after a serious burn? Well, today we're going deep inside the official 2025 burn and scald procedures from St. Bernard's Hospital. We're going to follow that hidden step-by-step system that takes a moment of pure pain and turns it to a planned, methodical path to recovery.
So here's our roadmap. We'll trace a patient's entire journey, right from that first moment all the way to the final advice. We're using the hospital's official guidelines, and you'll see how every single step is part of this carefully designed, evidence-based plan. All right, let's get started.
Okay, so let's jump right in. We'll start with a scene that's all too easy to imagine. Just a simple, painful mistake at home, but one that kicks a massive system into gear.
Yeah, it always starts with something so familiar, doesn't it? A spilled drink, touching a hot pan for just a second. But these little mistakes, they add up. Globally, burns are actually the fourth most common type of trauma. And you know, the real number is probably way higher, because most of us, if we get a minor burn, we just treat it at home. We never become an official statistic. But just to get a sense of the scale of the problem, we can look at data from the UK, which helps inform these guidelines. We're talking about 250,000 burn injuries every single year. And out of those, a massive 175,000 are serious enough to land someone in A&E. And this, right here, is why these standardized procedures are so incredibly vital. The GHA protocol is built on one crucial fact. Burns don't happen to everyone equally. They hit the most vulnerable among us the hardest. We're talking young kids and the elderly. The entire system we're about to walk through is designed specifically with their safety in mind. Okay, let's move on to the next stage. Our hypothetical patient has just arrived at St. Bernard's Hospital. The clock is ticking and the assessment starts right away. This is where information is everything. So, what's the first thing a doctor needs to know? You might think it's all about the burn itself, but no. Before they even get a close look at the wound, they've got to build this rapid-fire profile of both the patient and the incident. This is basically their initial checklist, and it's all about sniffing out hidden risks, you know? Does the patient have diabetes? That could totally change how they heal. Was the burn caused by a fall? Maybe there's another issue going on. Every single answer here helps build the treatment plan and flags potential problems right from the get-go. Next, they have to put a number on it. They need to quantify the injury. To do that, they use this critical measurement called total body surface area, or TBSA. And this isn't just about size. This percentage is one of the key deciders for how severe the burn is and what treatment path they're going to follow. Now this is what I find really interesting. This is a direct quote from the official hospital procedure. It's a really frank admission that pain is a huge and often undertreated problem. You'd think that deeper burns would hurt more, right? But actually, superficial burns can be incredibly painful because all those nerve endings are still intact and exposed. And now we get to the absolute heart of the matter, the central decision point. Everything they've just assessed, the cause, the patient's history, the size, the depth, it all leads to one critical question that sends the patient's journey down two totally different roads. And here it is. This is the fork in the road. On one side, you've got a non-complex burn. I mean, it's painful for sure, but it's smaller and it's not in a critical area. But on the other side, you've got a complex burn. This one's deeper, bigger, or it's on a crucial part of the body, like the face or hands. This one decision, complex or not, dictates everything that happens next. So for now, let's follow the more common path, the non-complex burn. This is the kind of thing that's likely managed in a minor injuries unit, and the procedures here are all about one thing, creating the perfect environment for the body to heal itself. And this brings us to that age-old question. Do you pop a blister or not? Come on, we've all wondered about it. But in a hospital, it's not really a debate. It's a decision. And it's based on very specific rules laid out in the official procedure.
So here's the rule of thumb. If a blister is small and it's not super tight like the one on the left, they leave it alone. Why? Because it's basically a perfect, natural, sterile dressing. But if it's large, tense, or if it crosses a joint, clinicians will de-roof it, which is just a term for carefully removing that top layer of skin.
And they don't just do this for fun. De-roofing a blister lets a clinician actually see the true depth of the burn. It gets rid of dead tissue where an infection could start, and it relieves pressure that could actually damage the healthy tissue underneath. Every single reason on this list is about preventing a worse outcome down the line. Dressing the burn itself also follows a really clear procedure. First, it's cleansed with warmed saline, which is much more comfortable for the patient. Then, a specific type of dressing is chosen, and the key word here is non-adherent, something like a soft silicone dressing. This is so important because it protects the wound without that agony of it sticking when it's time to change it. But what if that burn was classified as complex right from the start? Or what if a supposedly simple burn just isn't healing like it's supposed to? Well, the system has this powerful built-in safety net with super strict rules for escalating care. This table is that safety net, and it leaves absolutely no room for debate. Just look at these triggers. A burn on the face, you call the surgical team. An electrical burn? Call the surgeons. A wound that hasn't healed in 2 weeks? You guessed it, call the surgeons. It's a clear, non-negotiable escalation path. There is zero guesswork involved. And then you have the biggest red flag of them all. If any burn patient, and it doesn't matter how big or small the burn is, starts to develop a fever, a rash, or confusion, it is immediately a medical emergency. The big fear here is toxic shock syndrome, which is a life-threatening condition. The rule is simple. You see these signs, you escalate immediately. Okay, finally, the journey doesn't just stop when the wound itself has closed. The protocol's duty of care actually extends into the recovery phase, and it has really clear advice for long-term skin health. And this is the final crucial step, the one that gets handed over to the patient. You see, healed skin isn't normal skin. It's often really dry, itchy, and super sensitive. The official advice is so simple. Moisturize it every single day with a basic, non-perfumed lotion. This one simple act is the last piece of the puzzle to make sure that new skin stays soft and healthy. So, what does this whole journey through one hospital's procedure really show us? It reveals that behind every single common injury, like that spilled cup of tea we started with, there is this incredibly uncommon system of rules and safety nets and critical decisions. It's a silent, almost invisible process of care, meticulously planned and just waiting for the moment it's needed most. All designed to give every single patient the best possible chance at a full recovery.